First of all, I suggest that you watch this video in HD and in full screen by adjusting the settings on your player so you can appreciate the fine details of the images. Once again, our normal chest X-ray is in front of us, and compare it with the X-ray that is visible on your left hand side. Now, if you have seen a few normal chest X-rays, you'll realize very quickly that there is definitely something wrong with the patient on your left hand side. The mediastinum is white in this area on this patient. There is a mass effect in aortopulmonary window, so the aortopulmonary window on this patient is this, which is normal, but there is a mass effect here, and there is a mass effect, there is a widening here in this part of mediastinum on the X-ray on the left hand side. So first thing that comes to mind after seeing the mediastinal widening in this area would be enlarged lymph nodes. You can see abnormal opacities in both lungs here as well, and there is an abnormal lucency here and in this area, and most probably in this area as well. You would agree that there is a reticulonodular pattern, and there are fibrotic changes in mid zones on both sides, and as the lung shrinks in volume as a result of fibrosis, it can produce what is known as traction bronchiectasis. So shrinking interstitium pulls bronchi to dilate them in a non-uniform. So this probably is a dilated bronchial branch. You can see thick walls on both sides, and this is the same thing, a dilated bronchial branch. An axial CT scan image from the same patient, a bit below from carina, and you can see calcified lymph nodes. You can see calcification here, and you can see calcification here. These are enlarged calcified lymph nodes. An HRCT image from the same patient, a cut taken just below the level of carina. So this is carina here, right main bronchus, left main bronchus, and you can see traction bronchiectasis here, here, and here as well. So the dilatation of the bronchial branches is visible clearly. So this is a bit small from here and a bit more dilated from here. You can see the thickened walls of the bronchial branches. Normal bronchial tree should taper towards the periphery, okay, which is not the case in this case. On this image, you can also see what are known as perilymphatic nodules visible on both lungs. These are nodules within interstitium which can be subpleural. They can also be present along the fissure or along the interlobular septae and or adjacent to bronchovascular bundles. But before I continue on this, I want to show you another image from a different patient. Okay, another image with perilymphatic nodules, and as I said, these are the nodules within interstitium. I guess it would be very difficult for a newbie to agree with me, but I just wanted to make a point, and the most convincing thing for me would be to show you this fissure, which is sort of beaded in shape, unlike this smooth and regular line. So these beaded shape structures are the perilymphatic nodules, which as I said can be present within the which can be present along the fissure and within the interlobular septae, as well as adjacent to bronchovascular bundles. So all the features mentioned so far, that is lung fibrosis, traction bronchiectasis, and the presence of perilymphatic nodules, are suggestive of interstitial lung disease. In this case, both the patients have been diagnosed with sarcoidosis. Please note that the patient, the first patient, also has enlarged lymph nodes, which along with the presence of all the features mentioned before should make you think of sarcoidosis. Also note that the most common cause of perilymphatic nodules is sarcoidosis, although they can be present in other interstitial conditions.